Good afternoon. My name is David Cassak of Windover Information, and it's my pleasure to welcome you to this, the latest in our series from the Innovator's Workbench. Joining me today in our interview of Dr. Simon Stertzer is Paul Yock. Paul is well known to you, a renowned figure in his own right. He is director of the Biodesign program here at Stanford and also co-chair of the bioengineering department. You know, for those of you who follow the series, know that the backgrounds of the folks we've interviewed is wide and varied. And yet, if there is a kind of archetypal medical device entrepreneur, it is that physician who, finding a clinically valuable and important new procedure, finds himself in the position of having developed technology to make that procedure work. And no one better exemplifies that than Dr. Simon Stertzer. Dr. Stertzer is best known to us, many of us in the medical device world, for his role at AVE, but he was also a true pioneer in the development of coronary angioplasty as a procedure here in the US, and we're fortunate to have him with us. So Dr. Stertzer, thanks very much for joining us today. And let me just begin by saying that I know you're raised in New York, you're actually an East Coaster like me, and that your early training was in medicine, but was not in cardiology. Where did you begin, and how did you get into cardiology as a field?
Well, I started out at the University of California in San Francisco in surgery, and I got interested in cardiology because cardiovascular surgery was, especially in congenitals and early valve surgery in the very early 60s, was beginning. And I went back to New York because we had a very much more developed, mature cardiology fellowship program in that era. Now, this is now going back 40 years, and so to say that there wasn't a really well-matured fellowship at the University of California in cardiology in 1962 is not an insult. But I went back to New York and ran into actually Andre Cournon, who won the Nobel Prize for right heart catheterization in New York, and I went through the medical program, became chief resident in that institution in NYU in Bellevue Medical Center, that at the time had the Columbia and Cornell division in addition. And of all the subspecialties, the emerging interest of one of our attending physicians in invasive cardiology was so intense and so impressive that I became his fellow after chief residency in New York.
Was Ed Reppert?
That was Ed Reppert.
Mm-hmm. So talk to us a little about where cardiology was at that point and how you became involved and how you got to the point where you were the one to do the first coronary angioplasty in the US. Obviously, at some point, you became involved and became aware of the work that Andres Gruncic was doing, but take us through that history.
Well, to make a very long story short, I am going to take the liberty of telling you that in many respects, the first coronary arteriogram in New York City was done by myself in about 1963 or 4. It was about a year after Mason, Sones, and Shirey wrote their initial paper in 1962. And I can tell you that to do a coronary angiogram 42 years ago in New York City or anywhere in the United States selectively was a remarkably adventurous procedure. In many respects, more so than doing angioplasty in 1978. There was a lot better preparation for it than there was for the coronary angiography, which we did on 8mm film. Mm-hmm. And I had to run the film, and actually it was 16mm film, and develop it myself by hand. And then we thought it was a tremendous advance to get 35mm motion pictures, never dreaming that you would see DICOM CDs of the caliber that you see today. However, again, to give you an idea of how far cardiology has gone, is to state that at that time, when we were trying to introduce coronary angiography into the East Coast and then the West Coast and then all over the country from the Midwest where it began, there were no coronary care units. Somebody with an acute myocardial infarction went into an open ward. During my fellowship, I did infants that were newborn in the catheterization laboratory to adults because pediatric catheterization had not yet been separated from adult cardiology. So that shows you that, in essence, as I was saying to Paul Yock before, that you've got yourself a dinosaur here, as much as I hate to say it.
Well, do you have a sense of what it was in your own practice or nature that led you to be the first in this space? Did you understand the trepidation that other doctors had? What was it that you think led you to go in areas where no other doctors really were going at that time?
Well, I think part of it was the influence of Ed Reppert. Ed Reppert was a pioneer. His training had come from Walter Reed Army Hospital, and this Cornon Walter Reed Army Hospital was the beginning of all invasive cardiology in the 60s. So that for somebody that was always looking out for a new edge to try to understand coronary disease, the first window we got was coronary angiography. And the justification for that, because there was none in 1963-64, people said, why are you doing this? It's just dangerous, and it's of no consequence whatsoever. Well, in 1967, Melvin Judkins came along, made it simpler, and so did Effler at the Cleveland Clinic by doing the first bypass, Effler and Favaloro. And the advent of bypass surgery justified coronary angiography. And so we went on developing coronary angiography as a triage for surgery, which was a monumental advance in internal medicine, until about 8 or 9 years later, somebody dumped on my desk some animal work that Andreas Grunzig was struggling with in Zurich, and said, what do you think of it? And I said, where is this fellow? And the person who dumped it on my desk said, well, he's in my apartment on Fifth Avenue right now, but he doesn't speak English. And my German was pretty pathetic, but Andreas learned English very, very quickly. And in 1977, in September, he did the first case in Zurich. And then we went to actually Kaltenbach's laboratory for some subsequent very early cases before there were a half a dozen. And finally, after 7 trips from New York to Zurich, and Andreas was into about 46 or 47 cases, he let me take the equipment from the Schneider Needle Company, the exact nature of which I don't think we have the time to describe, but it wasn't exactly guidant. And so we took back the equipment and brought it through customs. There was no FDA jurisdiction at the time. Customs just wanted to know how much the inflation device was worth and whether I was going to sell it. And we waited for an ideal patient, and on the 1st of March in 1978, I did the first case in New York. And several hours later, Myler and Grunzig did, just fortuitously, it wasn't planned that way, they did the first case on the West Coast in San Francisco on the same day. And then Myler and Grunzig and I gradually increased the number of people in the circle of people doing angioplasty in the very beginning. It consisted mainly of people who were willing to dodge tomatoes and eggs around the country, and we kind of bucked the establishment with something that we felt was so remarkably successful that it was worth the non-randomized enthusiasm that we had when it first started.
Simon, let me roll you back to that. I can't let you gloss over the first cases that easily, because I'm really curious about what you were worried about. You alluded to the equipment, and tell us a little bit more about that, and what were your concerns in doing those first cases? What set that scene?
Well, the biggest concern that I had, and I think we all had, was the all Teflon guiding catheter. The guiding catheter was one of the most dangerous interventional weapons I've ever seen. And it's all we had. It was pure Teflon, and it was 9 French, and it was inflexible. And so to gain access to the coronary arteries, it was a difficult and dangerous thing to do because it wasn't a flexible catheter. And it was of so much concern that I developed a brachial guiding catheter with USCI, which at that time was owned by Bard. And that brachial guiding catheter was a lot more like a Sohn's catheter. It was softer and it was easier to deal with, but it required the cut down going from the arm. And although there's been a whole resurgence of working from the arm under circumstances that you're mostly familiar with, the radial approaches and so on, it was strictly competitive for a while, and it was harder to do from the arm than the Judkins technique, but it was, in a sense, a little bit safer until the guiding catheter started to improve, which happened relatively quickly. But the guiding catheter was the most dangerous thing, and the most fundamentally primitive aspect of this, in answer to Paul's question, is that we had DG and DJ catheters, which were appellations from the German referring to whether the tip of the catheter had a curved wire or a straight wire, because there was no over-the-wire system until John Simpson really developed that with ACS several years later. And so we would enter the coronary through the guiding catheter with the balloon and attempt to go down a native vessel with no pre-wiring. And that's something which no fellow today will ever see again. And no fellow has seen it in the last 20 years probably, and no fellow will ever see it again, unless there are some very unusual circumstances whereby a guiding wire is not used first. And so those two things were probably the biggest difficulties. And in addition, the outer diameter of the balloon was monstrous compared to what the profiles that are achievable today in a kind of commodity sense, where you could literally exist with almost any major company's balloon and do nearly the same thing. That clearly was not the case with the original balloon catheters.
The other thing you alluded to was the relationship with the surgeons, and that I even remember that being really colorful times. Was that a local problem for you, or?
No, actually, we were very lucky. We had a great deal of support from the surgeons because there was such a groundswell of interest in sending patients with coronary disease that in the first few years, almost all of the patients that we had referred, we had to advise that they have surgery because their disease was way too complicated for the state of the art in 1979 or 80. As you know, as time went on, the equipment and the ability to deal with complex lesions and difficult cases and poor ventricles and grafts and so on has now led to an interventional cardiology practice that leaves a relatively small number of patients going for surgery. Mm-hmm. But in the beginning, it actually produced more work for surgeons.
Well, pick up on that, and I guess kind of two related questions was, how quickly did it take for the cardiology community to catch on and to begin to adopt this? And what about the first patients? How hard was it to convince them that you want to try something radically new on them as the form of treatment?
Well, I'll tell you, patients there are, in almost any class of patient, there are enough people who are interested in something special to help them, so that patients were more willing than we were on some of these patients. And remember, the inducement is really that, well, this is an experimental procedure, but if it's successful, you don't get bypass surgery, you don't get a sternotomy. So that's a lot easier than it is to attempt to gain patients for a treatment modality that has a certain fear to it that's greater than having your chest open. And so that was not the hard part. We had to exercise judgment in whom we were willing to apply this with the limited capability of the material to start. But it wasn't hard to find patients. It was much harder to convince colleagues in the establishment and outside the establishment. And by establishment, I mean the academic centers. We had some people that were very interested and very cooperative from the beginning, and we had many people who were so skeptical that they thought this was an outrageous way to approach coronary vascular disease for 5 to 6, 7, 8 years.
Now, you told me you recognized earlier this was a true breakthrough in treating of cardiovascular disease, but either in the months leading up to that first coronary angioplasty or in the years after, did you have any second thoughts, any misgivings that maybe in fact you weren't on the right track, that this procedure was not going to be as valuable a clinical advance as you'd originally thought?
No, I think I can honestly say that I didn't invent this procedure, and I didn't do the first procedure except in America. That was Andreas Grunsig, who did so again. Were he here today, he'd be the first to tell you that his ideas came from Zeidler and so on and so forth, who worked in the periphery, and Dotter. But it was really Andreas that did this. However, I will say that as soon as I saw this data, I knew that this was going to be here to stay. I just did. And I felt the same way about stents only after I really saw what Colombo was able to do to decrease the anticoagulation, because that was dragging on as a problem for quite a while. Although when that really clarified the use of a stent, I think that the same curtain lifted for me. But as far as angioplasty was concerned, I can remember in 1978 telling a press conference that, look, if we found a way to create a 2-year additional lifespan in somebody with leukemia or pancreatic cancer, it would be applied in everybody, even if it worked for 2 years. So my biggest concern was that maybe this would work for 2 years and then we'd be back to square one. I didn't know what would happen. I didn't know anything about restenosis when we started, except that it probably took place in the first 6 months, which we then learned was actually the case. But that's about all we knew about it. And my concern was it wouldn't be permanent and we wouldn't find a way to make it permanent. But as far as it's making a huge difference in the blood flow to the myocardium by just this balloon being inflated to X number of times, 4 or 5 times the pressure in your tires, as soon as I saw some objective data, I knew that was going to be a new industry.
You mentioned before that you developed a brachial catheter. It seems that you fairly quickly began to look not just at the procedure, but at the technology that we needed to make the procedure better. Talk about how and why you got interested in the device technology side of this procedure.
I think we all did. The original nucleus of 5 or 6 people that started doing this with Andreas were always aware of the fact that that whatever we were using was going to be part of, in the modern day parlance, a product cycle that was going to be very short. Mm-hmm. We knew that we needed better equipment, and so we were always on the lookout for something that would make it easier. Some of us were more ingenious than others, like Dr. Simpson and Dr. Yock, but but we were always looking out for it.
So talk about some of the early initial advances and some of the places that you went. Eventually you're going to get to AVE and this coronary stent, but talk about some of the steps all along the way that got us to the point where you were playing a greater and greater role in technology development.
Well, as I say, we once we got established as well-known people in interventional cardiology, I moved back to California at the request of my ex-partner, Dr. Myler, and I worked with him for 10 years before going to Stanford 10 years ago. And I have to say, in fairness, that once we were established as so-called pioneers in a field whose names were known, people will bring you technology, and some of which you don't want to look at, and other things you say, geez, this is a very good idea, but what you need is to take it, and turn it that way, and they go back, and 2 months later they come with something that you suddenly think is ingenious. So I think there's a feedback once you get into a position where people show you technology and continually bring you technology, it begins to have a momentum of its own.
You and I were talking, and you had made the point that in those days, before ACS really began to take off, USCI had monopoly is not too large, but had really the large domain in this space, and it seemed to me that it was not your intent to be an entrepreneur from the very beginning, but that you expressed the notion that USCI was not as proactive in working with physicians as they might have been to capitalize on that early foothold.
Well, I don't know how to put that. I wouldn't put it that way. I'd say that USCI was the only company in let's say 1978, that was making diagnostic cardiac catheters. Cordis was very close behind, and I think Cordis didn't start doing that, and apologies if this is not temporally chronologically correct, but I think Judkins had to come first before the Cordis catheters, and I think that was 1967. So for about 2 or 3 years, give or take, USCI was the only repository, they were the only people who would listen to us to take a woven Dacron catheter, make one that was a guiding catheter, and then Judkins came along with, in the 60s, coronary angiography, and very quickly, when Cordis got wind of angioplasty, they started to make guiding catheters as well. And so, and it's very clear that the Judkins technique has, by and large, for training and day-to-day purposes, kind of driven out that brachial approach, and probably rightfully so, from spoken from the lips of somebody who really was married to the brachial technique in the 70s, early 70s.
So in 1990, AVE was formed. Talk to us about what you were doing in the decade of the 1980s in terms of both technology development and procedure development. Were you working with other companies? Were you working with startup companies to develop new technology? Were you basically waiting for technology to be developed that you could use that other people were developing?
No, I think during the period prior to the formation of AVE, my attitude towards startup business was that if it came along and was appropriate, I would do it. But basically, I was interested in doing 5 cases a day as well as I could, and making sure that I had the most advanced technical tools to do that. And if I could contribute to somebody else's bringing me an advanced technical tool, I would do that. It turned out that in the late 80s, I had worked on a number of stents that weren't very successful designs, and then I saw a design that looked to me to be very successful, and that was a separate project because we had many projects. I was at San Francisco Heart Institute at the time, and one project that had nothing to do with stents was really a conception of starting a balloon angioplasty company just with a balloon that would address better qualities of profile and passage ability, and just simply a better balloon for the mid-'80s. And at that time, it looked as though it wouldn't be a fruitful business decision to look for a market in the United States where the competition was already giant. So a proposal came to me that went something like this. There's a $20 million market worldwide, and there's X amount of a $200 million market, I think it was at the time, and there's X percentage of this that's foreign, and there was a business plan, in short, created to take a small portion of the OUS business and direct it towards arterial vascular engineering, which was a company that was basically started by myself, Jerry Doros, who, as you know, is an interventional physician, a few private investors, and Brad Gendersey, who was the chief and most critical engineer to us when the company started, and John Miller, who was the became the chief financial officer, and had probably the best business sense of anybody. And so we created a business plan that was designed, and I've long since forgotten the details of that business plan, but it was designed to get 10% of, I think, a $200 million market, and a $20 million business was considered by the investors to be not a bad thing to try to do in markets where you wouldn't be competing with ACS and USCI because they were so remote that we might be traveling to them to start angioplasty, but they weren't really first on the list for distribution from the big American companies. And that was the original focus. And so they were in a position to develop a conveyance for the stent that I was working on third or so, where I said, you know, this may really work. This has got some features that I'd like to see, but we can't deliver it properly. And we brought it to AVE against the protest of one of its officers who said, don't defocus the engineers. And
because it was essentially a balloon company at the time.
That's correct. That is correct. And so I was so impressed with how they were able to clean up the manufacturing of the device and its features and its integration with the balloon system that I felt it was a giant leap forward over what was going to become available as the first available stent in the United States and even the first available stent in Europe.
So you were still 2 years away from, in 1992 when you brought the stent to AV, we were still 2 years away from the launch of stents in the U.S. I know it's a sensitive.
It was only 2 years. It seems like about 10 to me.
I know it's a delicate issue, so if you can speak around it. But what was innovative? Because the success of AV was really driven by the stent technology. What was different about AV stent than the other stents that were in development at the time?
Well, all I can say about it today is going to be somewhat limited by the fact that some of these large companies are still trying to adjudicate some of the characteristics of these devices. So I will dance around that a little bit, except to say for purposes of instruction that if you took the AVE stent and its design and aligned it with the AVE balloon as developed by Gendersey and Lashinsky, who are two of the best engineering minds I've ever seen in interventional cardiology, not that there aren't scores of others, but those are the two that I had the privilege of working with. They created something that was so much easier to deal with. It was the first stent that could go almost anywhere the balloon could go. Mm-hmm. It was the first stent that could go stent in stent. I don't know if I'm the first person to ever put a stent in a stent, but I can tell you I did it with the AVE stent in Singapore or Jakarta or somewhere when we were trying to deal with what looked like an impossible situation whereby one company's stent had with great difficulty been seated, and then it looked like, oh my God, we've got to go distal to that, and the only thing at that time which was going to work was the AVE stent, its design and its delivery and so on. And the best way to analogize it, because it doesn't seem as though it has the same impact today, because so much time has gone by, 10 years or so have gone by. I remember as a young fellow after the Second World War, when General Motors stopped making tanks, they started to make automobiles again. And my father was very interested in automobiles. And he took me out one day and he said, I want to show you something that's going to change the world. And he walked me to his garage, and in there was an Oldsmobile in about 1947 or 48, something like that. And he said, you see this? It's only got a brake and it's only got an accelerator. It doesn't have a clutch. And I said, so what? And he said, well, you just take this stick and you move it here and you never have to change the gears. And even as a child, I said, well, I bet that's really going to go far. That is not a marginal improvement, you see. And so I think the AVE stent at the time was a huge change in a product, so that people used it in Europe and permitted the company to live off its European sales in a way that probably is a paradigm that can't be repeated today for any number of reasons. But at the time, it foreclosed on the requirement for B, C, D, F rounds of financing.
Well, I was going to say, I know that you spent most of your time on the technology and clinical sides at AV. AV seems to us, in retrospect, to be the quintessential medical device success. Innovative technology, successful public offering, dramatically successful sale to a large company, except in one regard, it took no venture capital money in its funding.
That I think it comes back to what I just said. It was to stent technology what Oldsmobile's first automatic transmission was to manual transmission. Today, that analogy holds going forward, in that you don't buy one automobile over another because they have automatic transmission, because they all do. So to a certain extent, it's difficult to explain why AVE was so successful in 2004. But in 1994, it was such that whether you liked me or Brad Gendersey or John Miller, and most people didn't, you would use it because it would go where you wanted it to go.
And yet you were saying to me that, I was saying to you that I thought that there must have been a lot of people clamoring to get in on the AVE, jump on the AVE bandwagon, but you said that a lot of people actually predicted that you guys wouldn't survive your first couple of years.
I don't know if I said that to you. I don't remember saying that. Somebody else must have said that. No, I don't think that AVE was too much on the radar screen until it started to emerge in Europe at various conferences where people grudgingly used it. And I say grudgingly because they, AVE didn't have a lot of money to support this conference and that conference. So it came out of the, it came off the shelf only in a demonstration course where somebody was having difficulty with some other modality. And it was able to survive because of, again, its unique product behavior. And so I think there are some products that will have a window of opportunity to do that. And then there are advances that naturally take place in the course of industrial development and competition. And this, I'm sure, rings a bell with everyone, and is something which we see everywhere and everything.
Your analogy of the manual shift to the automatic transmission suggests that you're looking for large leaps forward in technology. And I know for the last several years, you've been involved in a number of startups. I wonder if you can talk about where you see some promising technology going forward. And one technology that you were involved with, or one startup, was Quantum, which is a drug-eluting stent. What do you see as the future of drug-eluting stents and the future of drugs or biologically active agents as parts of cardiovascular device therapy going forward?
Well, I think that we know the modality works. We know that if we elute a drug into the area that we've just angioplastied, we can break a cycle of intracellular events that cause restenosis. I think what will change dramatically is the platform, if not the drug. But I think the principle's established, and I think we will see more variations on what is going to carry the drug and how that device is going to interface with I think you will see the polymer paradigm that we're now looking at outmoded fairly quickly with some extremely ingenious methods of doing the same thing, and perhaps with different drugs.
Mm-hmm. You're now into areas like vessel tissue engineering and intramyocardial delivery. Talk about some of those as promising new areas. And do you look at them as business opportunities, commercial opportunities, or do you see them more as clinical advances and therapeutic advances?
Well, I see them as clinical advances. I think that, and I've said this to a lot of people in this audience time and time again, I think the jury is still out on intramyocardial delivery, but I do think that myoblast therapy, active, vasoactive, and myoactive peptides, and progenitor stem cells, in some form or another, will have some role or can have some role in either myocardial or angiogenesis. And whereas I've been looking at this for about 4 years now, I don't see that this has been adjudicated negatively. At first it seemed very far out, and then it seemed to drag. Now I have the feeling that there's a little more positive information than negative, although it's a highly speculative and a difficult thing to imagine, but so was coronary angiography in 1962. So I think intramyocardial drug delivery or intramyocardial therapy of one sort or another will emerge with some polemic about the method of delivery and considerable polemic about the efficacy of what is delivered. But I think we're going to see a great deal of that in the next 5 years or so. And I think that one of the things, I did tell you this, that since AVE moved me unjustifiably to some semi-oracular status, I've seen 115 business plans since AVE, and I didn't see one before AVE unless I wrote it myself or contributed to it. I've gotten involved in about a dozen, and now I'm maybe actively involved in about 3 or 4. Fortunately, most of them have had technologies that have been either bought out or still ongoing. But I'm interested in things like tissue engineering, where I see a technology that will provide blood vessels for arteriovenous shunts, for saphenous vein grafts, in a way that I hope someday will provide autologous internal mammary arteries for people. Mm-hmm. So those, again, are, in my mind, things that kind of go back to the automatic shift.
Well, Simon, sorry, can I take you back to the coronary arteries? There's, I mean, with drug-coated stents, we kind of have solved the problem. Is that right, or is there something more to do with coronaries?
I think there's a lot more to do with coronaries. If we just go off the top of my head to total occlusions and to acute myocardial infarction, I think that the removal of tissue and the removal of thrombus and the cleaning out of saphenous vein grafts in a near 100% satisfactory way is something that will come. The same disadvantages that we see with protection devices and dealing with grafts and leaving microthrombi in acute myocardial infarction, I think we're on the verge of seeing that attacked in a way that will be able to remove or prevent microemboli. I think that'll be a major change in terms of interventional coronary, percutaneous coronary intervention. And I also have seen and at least on the drawing board, a mechanism for dealing with total occlusion that is going to, if that doesn't work, something like it will. Mm-hmm. And I think that also will expand the horizon of percutaneous intervention tremendously. And not to be forgotten is that while we're doing all of this, we've seen remarkable improvement in medical therapy. Mm-hmm. And if you just take something like statin drugs, I think there are people that we were treating with galloping atherosclerosis, whereby if we didn't get restenosis, we got new lesion after new lesion after new. We don't see that as much anymore, and I think that's because of medical therapy.
So that was the next thing I was going to ask you. I can't resist. Vulnerable plaque, vulnerable sections of arteries, is that a device solution in your mind? Where are we going with that?
I don't know the answer to that. I think it's a really good question, and I think that there's a lot of thought and money being given to it, but I don't have the answer myself. But I think it's a really important question, and I think that my guess is that we will find a way of suddenly getting a breakthrough with what a vulnerable plaque is all about and how to identify it. But I don't know how to do that right now.
Well, you think about innovative technology, some like vulnerable plaque or drug-eluting stents or tissue engineering bring kind of biologically active agents and kind of represent a new horizon or a new realm for medical device companies. And others seem more mechanical. Chronic total occlusions, are kind of mechanical, go back to the heyday when devices were simply a more efficient guide wire or a better balloon. Can you still get excited about the ones that are purely mechanical devices but that help physicians do procedures better as opposed to the ones that have this kind of more complex biology attached to them?
Well, I like them both, but I can tell you that in June I was in Dr. De La Fuente's laboratory in Argentina, and I know I did a couple of cases of moribund people with obstructions of major vessels, elderly people, near shock, with acute myocardial infarction, and was able to take out the entire clot and see a change in hemodynamics that I can't say was as exciting as the first 10 angioplasties I did, but I must say that made me feel as though to close the book on mechanical engineering solutions to intervention is a very short-sighted way of looking at things.
So, as you look forward, I know one of the issues you had in 1978 was that the instrumentation you were using to do these first coronary angioplasties was so primitive and so crude at the time. And you mentioned to me that there's just been such tremendous progress. It's like going from Orville Wright to the Concorde in the last 20 years. As you look out for the next 20 years, do those kinds of advances help build, or have we really kind of reached a golden age of interventional therapies as we stand right now? Is there room for as much improvement in the next several years as there been in the past several years?
Well, if you listen to Eric Topol, we're going to just go back to medicine and stop all of this. I think that it's a little premature to say that we are going to, in the next few years, in the foreseeable future, find a way to so efficiently treat atherosclerosis medically, either to prevent it or to reverse it, that we're not going to need tremendous improvement in intervention. And if you go back to Orville Wright and supersonic jet travel, I would point out to you that NASA just tested a ramjet engine that could probably take an airplane around the world in 3 hours. So, you know, the fact that we have supersonic jet capability that for many reasons we didn't commercialize yet, you're going to see that commercialized, and then sometime even beyond your lifetime, your children will probably see a ramjet go from Washington to Washington in 3 hours. So I think the same thing will happen with intervention. There isn't. Let me just summarize by saying that since 1977, since Grunzig's original angioplasty, if you look at percutaneous intervention every 5 years, you probably would say, God, we're not doing what we did 5 years ago. And that's true today, so why wouldn't it be true in 2009 and so on?
Great. Well, Dr. Stertzer, thank you very much for sharing your insights, and thank you for being with us on this program today.
You're welcome.
Thank you.